Routes of invasion. Bacteria reach the urinary tract through 4 routes. 1, the descending or excretory route. 2, the ascending or urethral route. 3, the lymphatic route. 4, direct invasion by trauma or rupture of a neighboring abscess. The descending or excretory route. Without stopping to debate the question whether or not the healthy kidney can transmit living bacteria in any number without injury to its secreting structure, we may accept as clinically proven, notably in the case of the typhoid bacillus, the fact that living bacteria may enter the urine from a kidney clinically sound. There is strong evidence for the belief that in the course of the various infectious diseases, even in tuberculosis, bacteria may be transmitted by the kidneys without leaving any appreciable trace of their passage through these organs. Inasmuch as it seems biologically impossible for the living cell to transmit a living bacterium, it is probable that normal kidneys transmitting healthy living bacteria actually suffer a temporary localized inflammation so slight as to escape observation. Crabtree's observations certainly seem to justify the theory that acute descending B. coli infection of the kidney, sufficiently intense to cause symptoms and to produce a marked temporary diminution of phenylsulfonephthalene output, may disappear so completely that a few weeks later the pathologist is unable to identify any lesions in the kidney. Such acute temporary infections may perhaps occur in otherwise normal kidneys, damaged only by the effort to excrete a large number of bacteria, while congested by the toxins of these very bacteria circulating in the blood. Such a combination would explain, for instance, the fact that about 1 case in 4 of typhoid fever suffers mild renal infection. Yet no relation has been established between the severity of the infectious disease or of its toxemia and the likelihood of renal infection resulting therefrom. Hence, we cannot but ask ourselves whether even in these cases the 1 infected case out of 4 is not perhaps infected because of some local cause of lessened resistance in the kidney. On the other hand, we must admit that colon infections, at least, are almost always bilateral. For the severe acute type of infection, we can usually find a mechanical accessory cause. But for the milder infection of the opposite kidney, we usually find no such cause. It is probable, therefore, that toxemia and massive doses of bacteria in the blood are the occasion of this opposite infection. In order to explain the fact that pyogenic cocci are relatively common in perinephritic abscess and colon bacilli relatively common in infections within the cavity of the kidney, Crabtree has evolved the ingenious theory that the pyogenic cocci exhibit in the kidney, as they do elsewhere in the body, a relative tendency to immediate pus production of considerable intensity as compared to that of the colon group. Reaching the kidney through the circulation, the pyogenic cocci set up their infection in the glomeruli, i.e. in the cortical portions of the kidney, whereas the colon bacilli are more likely to pass through the glomeruli and to attack the tubules. Hence, colon bacillus infection extends more readily to the pelvis of the kidney, coccus infection to the perinephritic tissue. The sources of excretory renal infection are innumerable. The bacteria may be derived from focal infection, abscesses in various parts of the body, or catarrhal infections of the various mucous membranes. The intestine is the usual source of Bacillus coli infection, but the other bacteria are derived from roots of teeth, tonsils, adenoids, furuncles, accessory nasal sinuses, appendicitis, salpingitis, etc. In the following section, reasons will be given for suspecting that the bladder, the prostate, and the vagina are not uncommon sources of descending infection in clinical conditions that have heretofore been considered instances of ascending infection.